Hi everyone. So my name is Faiza. I'm one of the rheumatology fellows. I'm going to be going over some of the diagnostic tests that are important for scleroderma. So we're going to go through some of the important blood tests, what exactly we are ticking off on all those lab requisitions that we send you for, including your kidney function, your blood counts, and looking at your muscle markers. We'll also be talking about why it's important to keep an eye on your blood pressure and additional testing, which is screening for lung disease, such as echoes and pulmonary function testing. So our immune system is a really complex part of our body. It's important because it helps protect us against bacteria and viruses. And unfortunately, in autoimmune disease like scleroderma, that balance is offset a bit. And so we have trouble with things like scleroderma and other autoimmune disease. So there are two parts of our immune system that work together. The first part is the innate immunity. So this is your fast-acting immune system. I'm just going to pick it up, yeah. So the innate immunity is your fast-acting, hardwired immune system. So this is like Superman attacking the bad guys. So he knows exactly what to do. He knows the neighborhood. He knows what's out there. And when something abnormal comes up, there's an attack plan in place, okay? So it's quick. The second part of your immune system is a little bit different. So this is next level. This is like the Justice League. So this is when all the players come in, and when there's a new problem or something more complex, your adaptive immune system kicks in. So your adaptive immune system is special because what it does is it has the ability to label problem cells so that your body can then identify them appropriately and then destroy them and get rid of them. So as you can see up there, that's the blue circle is a cell, and the little spots within it are abnormal markers or proteins, and the body ends up labeling them with these destruction labels, and they end up being destroyed. So these labels are called antibodies. Unfortunately, sometimes there's a little bit of an imbalance, and what happens is that your body recognizes your own cells as being abnormal. And so these destruction labels are created, and your own healthy cells can be targeted. And that's what we call autoantibodies. And that's what we have present in scleroderma. So one of the examples up there is SCL70. So one of the most important tests that we do is screening for an ANA, which is an anti-nuclear antigen. And this is really just a screen to tell you whether or not you have antibodies. So it answers that question, yes or no. It doesn't tell you which specific ones you actually have. So more than 90% of people with scleroderma will have a positive ANA. Once you have a positive ANA, we want to find out more information. And the next test that we do is an extractable-nuclear antigen, or the ENA. And the ENA looks at the specific antibodies that are in your blood, okay? The ones that we are specifically concerned about for scleroderma are anti-SCL70, anti-centromere, and anti-RNA Pol3. Based on previous studies, there is some correlation between those specific antibodies and what kind of scleroderma you have. But ultimately, it's your rheumatologist and specialist that will decide what kind of pattern or picture of scleroderma you have. It also prompts us to be more aware of specific complications depending on what your antibodies are. But it doesn't mean that we don't end up doing the testing for you. Everyone gets routine testing done, and which we'll talk about this in more detail. But some of those tests are listed up there. Another important test that we commonly order is a complete blood count, or CBC. And our CBC is broken down into more cell lines, and it reflects how well our bone marrow is functioning. And so other cells that we look out for are the red blood cells and the white blood cells and the platelets. So the red blood cells, or hemoglobin is another word that is sometimes used, can be a reflection of a number of things. So red blood cells are important in our body because they carry oxygen and transport oxygen. So when there is anemia or a low red blood cell count, it can cause symptoms like trouble breathing, fatigue. In scleroderma, you can get low red blood cell count or anemia for a number of reasons. These can include if there's bleeding from your stomach. In scleroderma, you can get something called a watermelon stomach, or if you have ulcers. Other important things to watch out for is active inflammation, and kidney disease can also cause anemia. And some of the medications that are there to treat scleroderma may also have an impact on your red blood cell count. Another important part of our testing is having a look at how well your kidneys are functioning. So kidneys have multiple purposes within the body. So they make urine, they get rid of the waste in your body, and they also act as a filtration system. They manage the salt levels and the fluid levels within your body as well. And they also help control your blood pressure. One of the markers that we look for within the blood is a creatinine level. And if your creatinine level is high, that can be a reflection of the kidneys not working as well. Scleroderma renal crisis is a medical emergency within scleroderma. And one of the important markers would be seeing that the creatinine level is elevated. So touching back on the point about kidneys acting as a filtration system, their job is to keep the blood and protein within the body. If there's any damage to the kidneys, they become leaky, and so that blood and protein might show up in the urine sample that is sent. So when we check a urinalysis, that's what we're doing. We're looking for any abnormal blood or protein in the urine. With scleroderma renal crisis, oftentimes it's protein that's what is leaking into the urine, and you'll have a positive urinalysis for protein. So to tell you a little bit more about scleroderma renal crisis, it's definitely something that all patients with scleroderma should be aware about. You can get a new onset high blood pressure, or your blood pressure can be more elevated than your baseline, and it can be even as little as 15 points. Unfortunately, some patients have a normal blood pressure when they have scleroderma renal crisis, about 10%, and that can make things a bit more tricky when you're trying to be assessed by, an emergency room doctor or another physician. So it's important that you also have a bit of awareness about this complication in scleroderma. So other things apart from the blood pressure is worsening kidney function. So as we talked about the creatinine before that we check in your blood, that level can become elevated in scleroderma renal crisis. And we would also check your urinalysis and look for any protein there. Some of the symptoms that you can get would be acute shortness of breath, fatigue, headache, vision changes, seizures, and new lower extremity swelling. So scleroderma renal crisis is really critical for us to recognize early and treat because it can lead to kidney damage. One of the medications that we use is called ACE inhibitor or angiotensin converting enzyme. Commonly, a lot of our patients are on ramipril for blood pressure. That's one example of that type of medication. And again, lab tests that we would use to help diagnose this would be looking at your blood count, your kidney function, and your urine tests. Finally, another marker that we look for in the blood is related to muscle inflammation. So with autoimmune disease and scleroderma, you can get inflammation in the muscles that results in pain or weakness. and we would check a CK level within the blood. And this is called a creatine kinase, so a little bit different than the creatinine, just to make things more confusing. But that's another marker we check. Other inflammatory markers that you'll hear quite a bit about are ESR and CRP, which is erythrocyte sedimentation rate, or SED rate, or C-reactive protein. When there's inflammation in your body, such as with scleroderma, these levels can go up. But this is a very non-specific marker, so you can get elevated levels of CRP and ESR with other diseases as well, like infection, even something as simple as a sore throat or a cut to the finger. And inflammation would be things like arthritis or muscle inflammation. We'll highlight these very briefly, but I think we're going to talk more about pulmonary hypertension and interstitial lung disease with our respirologists. But just going over some of the testing that's done. So we do routine echocardiograms, which is ultrasounds looking at the heart and the blood vessels around it, leading to lungs. And our main goal here when we order this test is to assess if there is any evidence of involvement of the vessels in your lung. So something that we call pulmonary arterial hypertension. So this is when there's high blood pressure and narrowing of the blood vessels carrying blood to the lungs. And it can put a strain on your heart, and you can get symptoms like shortness of breath and fatigue. So if any of these tests are abnormal, we would refer you to a specialist in pulmonary hypertension, like Dr. Hambley, who will chat with us later. Other investigations that we do include a chest x-ray, and this is basically capturing an image of the heart to see if there's any scarring. We worry particularly about interstitial lung disease. And again, that can cause symptoms of shortness of breath because the oxygen is not being transported appropriately through the lungs. Other testing that we do is pulmonary function testing. And with that, we can see how well your lungs are functioning. And if any of those tests are abnormal, we would refer you to a lung specialist to help with further management. So just to kind of summarize now of all the tests that we have gone over, one of the important tests is having a positive ANA, which tells us that you have autoantibodies. To find out more information about the specific antibodies that you have, we will do an ENA. So this is where we will find out if there's a SCL70 or anti-centromere antibody. It helps your doctors diagnose scleroderma and also be more aware which complications to watch out for. One important thing that I'd like to emphasize is that having a positive ANA or ENA does not necessarily mean you have scleroderma. And it's a question that comes up often with our rheumatologic diseases because patients become scared that they might have scleroderma or lupus. And so we like to stress that it's important you come to see a specialist who can review all your blood work and labs and also assess your clinical symptoms before they make a diagnosis. And as Dr. Larche had mentioned, we don't do these tests for fun. We want to help you with your disease and make sure that it gets treated appropriately and in a timely manner. So following up is very important. We want to see how you're doing, how your clinical symptoms are. We also want to keep track of your labs and investigations blood work to make sure that there isn't any other organ involvement or damage. And we keep an eye on your blood pressure as well to watch out for things like scleroderma renal crisis. And again, recognizing disease activity early is key so that we can refer you to the right people to help you out. So that concludes my talk, and then we'll move on to some questions now.
got time for a few questions. We have time for a few questions now, if you'd like. And there's coffee outside, if you don't like. So we could do some questions now if anybody has any burning questions. I don't see any. Oh yes, thank you.
It's not exactly burning, but it is a question. One of the things that I'm often confused about is who should be doing the testing. So I see a family doctor, I see a rheumatologist. Who kind of coordinates or oversees what should be tested when? I sometimes feel like I shouldn't be asking, and yet periods of time can go by where something isn't checked. So now I'm kind of really getting an understanding of how important this data is to the overall management.
So did everyone hear that question? Who should be coordinating everything?
So I think ultimately it's nice to have like a team. You have your respirologist, your family doctor, and your rheumatologist, but one person should be taking a leadership role in organizing and following those testing. So oftentimes it's the rheumatologist that is going to be spearheading that. But say if they do refer you to a respirologist, then they might take over the piece about the pulmonary function testing or like the 6-minute walk test. But at the end of the day, the person that is going to keep track and make sure that all the people are doing those tests is your rheumatologist.
So I view my role as a quarterback. I know I'm not broad enough, and maybe I just need some shoulder pads. But anyway, I view the rheumatologist role as being the quarterback, and we like to have the balls thrown to us so that we can throw to the next person, right? And that's why I get upset in clinic when I don't have the lung function results or the echo results or whatever. So because I can't throw the ball to the next person if I don't have it. So that's our role. There's another question.
Yes. I didn't hear you mention anything regarding the weight loss and also chills. I experienced severe chills and I lost about 15 pounds as part of the scleroderma.
So thank you for that question. Weight loss is a big problem in patients with scleroderma. Maureen can jump in here right now. Just before Maureen jumps in, weight loss we always take seriously in medicine because there can be a very sinister cause for weight loss. So we always take it seriously, but scleroderma itself can lead to weight loss. So I'll hand over to Maureen for a bit.
I know that for a number of us, and certainly myself included, on the very beginning of my illness, I was losing a ton of weight. Probably lost about 30 pounds in 6 months. And I was very concerned. And it was when I started modifying what I was eating that I found it was better. And it was actually a naturopath who had suggested to me. You see, the sicker I got and the more tired I was and the more weight I lost, the healthier I ate. More fresh fruits, more fresh vegetables, all of the things that traditional food guide would tell you to do. When in fact she was the one who suggested if I went to liquid multivitamins, if I used soups and stews and steamed fruits, that I would be able to get the nutrients out of the food because my GI was moving so quickly. I was actually malnourished. Mm-hmm. My body just couldn't break it down and pull the nutrients as well. So by doing that, my energy levels came back, I stabilized my weight loss, and that was actually before I was actually diagnosed. So that would be what I would suggest you might consider.
Yes, I do have basically a Mediterranean diet, so eating all these fruit, vegetables, and fish, it's just coming on.
Just cook it. Yeah. Same diet, just try cooking things instead of staying with the fresh salads. I think of salads, which I love, as candy, because nutritionally in the beginning and when I'm in trouble, nutritionally it has the same value to me because I'm not getting anything from it.
Okay, if there are no more questions right now, we'll move on to a break, have a bit of a stretch of your legs, and then we've got the heavy hitters coming in after the break.